Thank you, Morgan, for this kind introduction. Thank you for Astellas team for the invitation. So, Professor Montorsi gave you a great overview of the first generation of therapy in prostate cancer, and we have to move forward at the step of castration resistance, and my speak will be about the recent data and future consideration regarding the first-line treatment in mCRPC prostate cancer. So as you know, the field of the castration-resistant management are hugely evolved during the last decades. We have at least 6 drugs that have proven to be effective for life prolongation. The first one was docetaxel in 2004, followed by new generation hormone therapy, abiraterone and enzalutamide, a vaccine, a new taxane, cabazitaxel, and the radium-223. So there is now a huge population of drugs that we can use, and thanks to these drugs, we have we can see improved prognosis for our patients. And when you compare the prognosis of patients at the castration-resistant stage, the survival has been almost doubled, reaching more than 3 years in most recent population cohorts. So by using these life-prolonging drugs, we can improve the quantity of life of the patient. The question is, can we optimize these outcomes by identifying for one patient the ideal sequence and the ideal combination of drugs? Given the rapid proliferation of systemic therapies, I truly think that this question of the sequence, this question of the first line, is one of the major considerations for the near future. So we have l'embarras du choix, we can call this in France, so the difficulty to make a choice. We have 6 drugs, 1 disease, so 720 possibilities of treatment sequences. Unfortunately, only 4 drugs are available in France, and I think we can just note that France is a developing country for some public health issues, but it still represents 24 possibilities of treatments. And without putting you under excessive pressure, I truly think that the most important choice is the first one, because the drug will never be so effective as when given early. So the first question is, do we have to start the treatment early, or can we wait for the first treatment? One hypothesis will be that if you can postpone the first treatment, you could delay the time to resistance and the time to progression. One way to wait is to manipulate the hormonal balance. You can do that by adding bicalutamide, by withdrawing the antiandrogen, or by adding estrogen. We know that this impact, the impact of this manipulation can be visible and reassuring for the patient and for the physician, but this PSA response will be transitory, and no clinical study has ever proven any survival benefit from this manipulation. And today we have at least 2 phase 2 trials exploring the impact of early treatment. The first one is the TERRAIN study. This study has randomized patients between bicalutamide and enzalutamide at the castration-resistant stage. And these survival curves perfectly show that enzalutamide significantly improves the progression-free survival in your patients. In this study, progression was defined by death, radiographic progression, or treatment change. Another phase 2 trial, the STRIVE study, have been published with the same design, the same methodology, but it included 1/3 of patients with M0 disease, without metastatic disease. So the results were strictly comparable to the TERRAIN trial. So these 2 studies has led to an evolution of the guidelines. And the first recommendation is that now hormonal manipulation are not recommended with a high level of evidence. And when the patient is under a complete blockade with antiandrogen, you have to stop it, but do not wait for a potential withdrawal syndrome before therapy change. So let's treat early, but how to treat? The first question we'll discuss during your tumor board is the choice between hormone and chemotherapy. When referring to the EAU guidelines, you can see that chemotherapy is mainly given to patients with visceral metastatic disease or patients with symptoms. And in France, we have the same recommendation, hopefully. Globally, patients with few or no symptoms will be preferably treated by hormone therapy, and patients with visceral metastatic high volume disease, rapid evolution or short duration of hormone sensitivity will be treated by chemotherapy. But keep in mind that these recommendations are stated with a low level of evidence, level 3, grade B, because no head-to-head trial has yet compared all the different treatment options. So these recommendations are mainly based on the inclusion criteria from licensing trial. This does not mean that chemotherapy is the only effective drug in patients with visceral metastatic disease. Let's take the example of enzalutamide and the PREVAIL study. In this study, 12% of the patients in the overall population had visceral metastatic disease. And when you look at the oncological outcomes, when stratifying the radiographic progression-free survival according to the site of metastasis, there was no difference regarding the efficacy of abiraterone, whatever the site of metastasis. In a subgroup of patients with metastatic disease, you can see that enzalutamide improved the survival by 72%. So this means that if you have one patient with visceral metastatic disease or high volume disease who are not fit for or refuse chemotherapy, new generation hormone therapy will be benefit from this patient. So you choose a new generation hormone therapy, but which one? Enzalutamide or abiraterone? When you look at the literature, there is no formal or informal evidence to support the use of this new therapy in one sequence over another. In other terms, decisions should be made without any significant evidence. Until now, the good sense recommendation were to use the most active treatment first of all, and the least toxic treatment first of all. Great, but it doesn't help too much. Indeed, high-grade toxicities with new generation hormone therapy are infrequent, so this argument is not so selective. The time to progression after this treatment is also clearly related to the time of initiation. And when you look at the figure on the right, you clearly see that the time to progression under enzalutamide highly depends on the time of initiation, and this time to progression dramatically decreases with the advancement of the disease and with the number of lines received. So this is not fair to compare separate phase 3 trials. We need head-to-head trials. And is there something new this year regarding the sequence? 3 retrospective studies have been published, and 1 ongoing prospective trial has been presented during the last ASCO meeting. So we're going to start with the 3 retrospective studies. 1 study comes from the Baltimore team, the other one from the Kyoto University, and the third one is just a pooled analysis of both cohorts. The primary endpoint used was the progression-free survival that was calculated from the initiation of treatment 1 to the progression on treatment 2. And when you look at the curves, these curves favoring the sequence abiraterone then enzalutamide with or without statistical significance in series. When you look at the PSA response, there was no primary difference regarding the primary resistance rates between the 2 drugs. And there were more PSA response superior to 50% in patients receiving enzalutamide. What about the difference when looking at a solid endpoint? Without big surprise, there was no difference between the groups. The overall survival was strictly similar, whatever the sequence. I just want to highlight some important limitations from these retrospective studies. Several prognostic factors, such as the duration of hormone sensitivity, are not reported. The reasons behind the choice of a given treatment are also unknown, and probably the dates of market authorization of each drug are clearly influence the heterogeneity of both cohorts. When you look at the Johns Hopkins cohort, only 16% of patients receive enzalutamide as first-line treatment, and in Kyoto University, only more than 80% of patients receive enzalutamide. So only the pooled analysis could provide us a relatively homogeneous distribution between these two cohorts. So cohorts were small, comparison statistically debatable. We don't know the reason for treatment changes. This was for progression or for toxicity. And more importantly, we don't have any data from the patient with a rapid evolution after the first line who did receive chemotherapy after abiraterone or enzalutamide as first line therapy. So to conclude, we cannot conclude. What about the the prospective trial? This trial was has been presented in the last ASCO meeting. 200 treatment-naive patients were randomized between the sequence abiraterone then enzalutamide versus enzalutamide then abiraterone. The primary endpoint was the time to progression from treatment 1 to progression on treatment 2. What are the results regarding the PSA response? The PSA reduction at 3 weeks was significantly better in the enzalutamide arms with significant p-values. But when you look at the preliminary results of the progression after the first line, the curves were not significantly different. So there was no difference between abiraterone and enzalutamide at first line therapy. So we cannot conclude. So how to choose? And who choose finally the treatment for one patient? Given that no oncologic benefit favors one sequence, you have to look at the patient comorbidity profile and the drug safety profile. This table shows the anticipated high-grade toxicities for 4 drugs, docetaxel, abiraterone, enzalutamide, and cabazitaxel. This simple table and the drug safety profile should help you to choose the best drug for one patient. For one patient who has a medical history of epilepsy, we would choose abiraterone. For one patient with a major contraindication to corticoid, you will choose enzalutamide. But finally, these medical conditions do not conserve the very vast majority of patients. So we need to consider other parameters. I'm truly convinced that you have to involve the patient in the choice of treatment. The reporting of patient-related outcomes are fundamental, and several phase 4 studies are ongoing with a regular and systematic assessment of the adverse effect of the quality of life by the patient himself. And when you look at these studies from Dr. Gravis and colleagues, this is a post-hoc analysis of the JETUC-15 trials. There is clear difference between the assessment by the physician and by the patient himself. So during the medical visit, you should be able to anticipate, to understand what is the most important functions the patient wants to preserve or wants to improve. Last quick question, and maybe this question is more for Constance and the oncologist. If you go for chemotherapy, what kind of chemotherapy do you choose? Docetaxel or cabazitaxel? Docetaxel is the historic standard of care first-line chemotherapy, but cabazitaxel has proven to be effective at a more advanced stage with different safety profiles. So it could be an alternative option. But now we have the response. The FIRSTANA studies have just been published and has randomized in a 3-arm superiority trial, docetaxel and 2 doses of cabazitaxel. And the main conclusion was that cabazitaxel does not demonstrate any superiority over docetaxel for overall survival. So in practice, docetaxel first and no change in chemo regimen. How will things change in the future? Probably we will move towards a personalized medicine, not only based on the patient profile, the drug safety, and the disease characteristics, but also based on molecular predictive marker for response. Everyone, I think, in this audience know the IRV7, the splice variant, but the test is not yet used in clinical practice. Several studies, a research team also shown contradictory findings. The recent publication from the Baltimore team seems to show that taxane could be the drug of choice, in case of IRV7 positivity, but clearly confirmatory findings are awaiting. The link between DNA mismatch repair defects and the sensitivity to PARP inhibitors are also another step towards a personalized and molecular-based medicine. Things won't be easier in the near future, sorry for you, but now we are facing clinical settings that will change in the future. Chemotherapy and abiraterone are now given in patients at the hormone-sensitive stage. So we will treat in the near future daily patients who would have received chemotherapy, abiraterone, and in the future enzalutamide at the hormone-sensitive stage. So the question is the response to a re-challenge will be exactly the same compared with the response to a real first-line setting? And preliminary data from the JTUG-15 trial tending to show that patients receiving first-line chemotherapy will be more sensitive to new generation hormone therapy rather than a new chemotherapy. Another important point is the number of lines a patient can receive. In this American study, the number of lines is highly predictive for overall survival, more than the sequence. So the sequence is important, but what is more important and clinically relevant is the number of lines a patient can receive. So try to keep the patient in a shape as good as possible to receive multiple line therapies. So to conclude, some key points. Treat early your patient without waiting for potential non-effective hormonal manipulation. Do not combine life-prolonging drugs because evidence has not yet demonstrated any synergistic effects of these drugs. Do not forget that androgen receptor targeting drugs are efficient in high volume and visceral metastatic disease. Let's involve the patient in the choice, and you have to identify with the patient the most function he wants to preserve or he wants to improve and adapt your treatment in function of. Let's hope that in the near future, some biomarkers will help us to guide the treatment and to adapt and to anticipate the response to the treatment. And once again, just a word to say that mCRPC disease is a chronic disease with a multi-step treatment, so try to keep the patient in a good shape to receive multiple line therapies. Thank you.
Thank you, Guillaume. Please come here and join us. Meanwhile, Alexandre is going to step on the podium. We'll discuss a little bit with you. Is there any question for Guillaume from the audience on the floor? Okay, me, I have a question for you, Guillaume. The thing is that you are talking about the line and the treatment, but we have seen that in the guidelines and in the reality of the practice, the lines have been evolving in the last 10 years. It was post-chemo, now it's pre-chemo. Do you see, in your opinion, any potential use of this new generation drug, enzalutamide, as a first line? Is it going to, at some point, challenge the agonist and I would say the traditional treatment? Do you see any potential interest earlier in the natural history of the disease? And are you aware of any ongoing development to the potential interest and utility of enzalutamide earlier?
I'm sure that there is a utility before in the malady, in the disease. Merci, Margaret. In the disease. You saw the results from the Latitude trial, and some trials are coming with enzalutamide. So I think the trend is to reinforce the hormonal burden, to increase the pressure on the tumor cells with enzalutamide, with abiraterone. And I think there is a hope maybe one day to heal the disease even in the metastatic setting. So clearly all the lines are moving a bit earlier in the disease, and some phase 3 trials are oncoming. It's sure that the results will be positive.
Okay.